Hello and welcome to the RDH View. Thank you so much for joining us. We are excited to share with you the new classifications of periodontal and peri-implant diseases and conditions. I'm here with my great friends and cast members. My name is Kathleen Bocrossi. I am the president of RDH and I'm also the moderator for today, so I will make sure we stay on track. And so yes, Carrie, would you like to introduce yourself?
Sure. Nice to see everybody. Please, we're excited to have you here. My name is Carrie Lepacek. I am a clinical hygienist. I work with OraVital and I do lecturing.
And I am Beth Parks, and I work with Kathleen as her educational director at RDHU, as well as one of the quality assurance coaches at RDHU.
And I'm Anna Louise Tolan, and I also practice clinically, and I'm out there trying to spread the word about great hygiene and how we can advance our profession as well. And so thanks, Sia, for joining us. This is a big topic.
Yes. Yeah, and we're fortunate because both Carrie and Anna Louise speak on this topic. And Beth and I are quality assurance coaches, and we see a lot of people doing their goals, creating their goals on this topic, and I think a lot of people are really confused about it. So we got a lot of questions from everybody to things that we want to talk about.
Right.
But so what we want to do is really try to demystify the new classifications as much as possible, so we can help you within your daily practice.
Yeah, absolutely.
Yeah, I think we need to suggest to you that this is a mammoth amount of paper, 17 papers that were put together, and you're going to have to read about it, and you're going to have to go to courses, and you're going to have to work with it in order to become proficient at it. Like, you know, it's just like any skill that you've developed through your hygiene practice, that you're going to start to work with it. You kind of have to jump in and give it a whirl, but you need to like pick smaller chunks. You know, I think the first goal would be to just even understand it.
It's like speaking a new language. So when you start to understand a new language, you can't start and have a full conversation. And I think the hardest part is that hygienists and dental professionals at large are terrified of the amount of information. So we're almost like decision paralysis. We're scared to make the wrong decisions, so we don't start to do it. And by not doing it, we're almost doing a disservice. And so we really need to get comfortable and just start it. So today is just an overview of a lot of things. Anna Louise and I will go into great details in some of our courses, but you've got to go back to the basics, start somewhere, start small and simple, and really it will start to make sense once you actually start to use it.
I think that's great advice, and what's going to be great about today too is we've had the opportunity to speak to a lot of you. You've sent in your questions. So the questions you have are probably questions a lot of your peers and colleagues have. So this will be very informative, but also a very practical look at the guidelines.
Right.
Yes,
And it's never easy to start anything new. And like you say, start at the basics. And I was speaking with someone yesterday and she says, I'm really trying to implement it. But she says it's not a habit yet. So that's just it. But at least, you know, a lot of people print off the staging and grading, they laminate it, they follow it throughout their day. But it's not ingrained in us yet, and that's just like anything new that we try, right? So we hope to help make the transition a little bit easier for you, and hope that this is a good segue to other possibilities. You could always join us at our courses that we have and that type of thing to learn more. And there's other, there's so much information about it that we'll share with you afterwards as well, that we will send out a follow-up email with extra resources to help you. And also we'll be sharing some pictures and diagrams with you today. You might not see it so clearly on the Facebook Live group, but we will be inserting them for the final product. So we will be editing and adding those in so for future viewing as well, okay?
So Carrie, why don't you start with about why there's a new system?
Well, the old classification system was basically from 1999, which is a long time ago, ladies, and it's kind of exciting to have a refresh on it. And they actually started to talk about health. Like, we actually have a category now solely and strictly a goal that could be on understanding healthy mouths and healthy dentition. And so we're going to break that down. There's a whole bunch of working groups that way. And the other thing is we wanted to bring it into a system that other people will understand. So when you talk to your medical doctors and you're collaborating, saying someone has aggressive periodontitis doesn't really mean anything to a cardiologist. But if you say my patient has stage 3 grade C, that is a language that they somewhat understand. So this will make it easier. And this is a universal language. This is across the countries. And so this is kind of exciting. You can really communicate and understand, and we can share knowledge. Is there anything else you want to add to that?
No, but I want to talk about like a little bit how it's going to help the dental profession.
Yes.
I think that we're going to see, first of all, you have to understand this framework was built to engulf and enjoy, to expand as new research comes out. So it's not only for today, it's meant to grow. So as far as being able to talk from one clinician to another, it's wonderful. And we're also going to start to see studies that say, okay, so this patient started out as grade and stage, so that then they can make determinations about treatment planning and what works best. So it's going to be great for research. It's definitely great for us working clinician to clinician. And then when we're trying to do some collaborative work with our healthcare providers, like Carrie has said, it's going to mean a whole lot more. So it is a great step forward for us to be treating periodontal disease and recognizing so many more facets, because since 1999 there's been a lot of science, right? And so we're going to see this. It's going to keep coming again and again, and we're going to get more views of implementation.
Right.
So we're going to hear more and more about it. So yes, you're just going to have to kind of jump in with us and give it a whirl.
But I like what you said. It's not only giving a strategy towards treating it, but it's making room for new science. So we don't know what we don't know. So it's making room for advancements, which is very exciting.
Yeah, it is very exciting.
And it's really given us a lot more parameters. When we start talking about the stage 1, stage 2, stage 3, stage 4, there are certain things and parameters. So op to op, hygienist to hygienist, we are going to end up coming up with a very similar classification from patient to patient. So it's really, really exciting. And it brings in the fact that as dental hygienists, we really are excited about perio, and we want to make sure we've got our periodontal assessments done and up to date and that they're complete, because we need all that data, we need all that record keeping in order to properly use this.
Exactly.
Well, I think there was a good question that came in. It was talking about when are offices supposed to implement this classification system into the practice?
Yes. And then further they said, is the person who asked that said, is there a mandated timeline from the CDHO?
Right. The loaded question.
Yeah, it certainly is. We had a great conversation with CDHO on Friday.
Yes, we
did. And we definitely got the affirmation that we need to be using it now.
Yes.
Yeah.
Yes.
So they are expecting to see this in your notes now. And so we're going to talk about when you have the data to make the statement, and you can use it as your dental hygiene diagnosis. So, as we go through, we'll point out those steps so you don't miss anything that you're going to need to be able to do that. But yes, so if
the time is now.
The time is now.
And the practice advisors at CDHO are very versed in this. So they're there to answer your questions. If you have questions on this, feel free to reach out to them. That's one thing they had said, that they hadn't had many questions on this up to this point. So please, you know what? They're there to help us. That's what their role is. So if you've got questions on this or other topics, please reach out. They really are there for support.
A lot of our members are from across the country. So we have some people on from BC, Alberta, and the East Coast. And so whatever, I would suggest that not just for the CDHO, but for your own regulatory body, if you have any questions, they're there to answer those or to help you as much as possible. So feel free to reach out.
Yeah, reach out to your practice advisors. That's why they're there.
It helps them also, as the regulatory bodies, know what their members have questions about. So
if nobody calls, they don't know that anyone's uncomfortable with it, or they don't know that there could be a concern, right? Until we bring that up to them, then they can, come out with their own statements.
Yeah, exactly.
So today what we're going to focus on is basically there are 4 working groups, but today we're going to try to highlight and touch on on 3 of them. We're going to talk about work group 1, which is periodontal health and gingival disease and conditions. We're going to talk on work group 2, which is periodontitis, and work group 4, which is peri-implant diseases and conditions. There is also a work group 3, which we want to mention, but we don't have time to go into periodontal manifestations of systemic disease and development of acquired conditions. That can be another learning goal, or later on we can come back and talk about it. Anna Louise, why don't you enlighten us a little bit about the periodontal health category?
Great. So the periodontal health category is an exciting category because never before have they defined what health is. And so that was a big deal to get that definition and making sure they all agree. And for many reasons that we can't go through today, health is considered to be the lack of edema and bleeding and suppuration, but up to 10% bleeding points when you do your periodontal evaluation would still be considered in the health category. It does have a further stipulation of whether it's an intact periodontium or a reduced periodontium. And we're going to show you some pictures of what intact and reduced is. So if you have a client who is, let's say, in their 20s and has very limited bleeding points and has all of their tissue, so I'm just going to show you a picture here, their tissue and their bone levels are looking like they are ideal, then this would be considered an intact periodontium. Okay, and this client could have be considered healthy because they have only 1 or 2 bleeding points. And likewise, we could consider this particular client healthy also. This client is considered to have a reduced periodontium, and this means that this particular client has some reduction of tissue level related to recession, but has not lost bone. So it's less than a 15% bone loss. And that would be stating because they don't have all of their tissue, like your other client that we showed you initially, that this would be a reduced periodontium. So just recognizing that they have less tissue because of the recession that they have. But they can also achieve health. So that's pretty cool.
It's very cool.
Yeah, it's very encouraging. So at first, when I first started, as you're implementing it, I was telling these ladies, so all of a sudden, I was doing this PE for this particular gentleman, and he only had 2 bleeding points on this day, and I was like all excited about that, and we had talked about that, and then all of a sudden it dawns on me, this gentleman is in health, in a reduced periodontium. And I was like, I did it! I did it!
I'm glad you're not the one that does that, because as I'm worried, I'm like, oh, I'm so excited, this is this case, or you're trying to build something, and you're like, oh, this would be a great example, and I'm like, I'm sorry I'm excited that you've got disease, but I need to use you as an example when I talk to the greater good.
Yes, that's why you two teach this course. But Anna Louise, what you're saying just shows the importance of proper recording of not only the pocket depths, but get those bleeding points. Accurate bleeding points too, not just I think there was one on the distal, but accurate bleeding.
I understand for everybody out there that it can be a challenging process to properly take a periodontal evaluation at the beginning of the appointment. That is a challenge.
At the beginning is the goal for
Not
getting
the
right records, the right documentation, especially with the bleeding, because that can be modified as soon as we go into oral.
And really, it's the foundation. Like they have to have this information. They have to collect that data in order to make that statement, right? You can't come to that conclusion unless you're
we've got to make sure we're
documenting all this.
Exactly. You've got to have the pocket depths, the bleeding, the furcations, the mobilities. You've got to have the
recession.
whole recession. Yes, absolutely. You've got to have it all down to understand where someone is, as well as the nice thing about this new information is we look at past data. So you're going to track people. Have there been changes over a period of time? And so that's kind of exciting because we've worked in practices long enough that we can. Just a little pause for a second there. That's okay. As well as the nice thing about there we go. I was just saying it's nice because you can track people over a period of time and then see that nothing has changed, or you will slowly see modifications and you know that patient's not stable and maybe there is an undiagnosed systemic condition that's leading to the progression because you don't see anything clinically. So
exactly. So now we have a definition for health, and now the next category in this particular beginning work group 1 is about gingivitis. And so we're talking about gingivitis. If there's less than 10% spots have gingivitis, then that's incipient gingivitis. And then we have localized, which would take you up to 30 of the dentition. And then after that, you would have a generalized statement. Okay. And because it is, a changing, it's a fluid thing, then it doesn't go past the mucogingival line, right? So then we know that that's gingivitis. Okay. And the other part of this category are gingival diseases that are affected by a medical situation. And so we're not going to go into those today because just learning, see, this is what we need to do is you need to block in certain areas so that you are going to not bite off too much.
Yeah, and I think focusing on the 80%, there are maybe not even 20% of people that would fall into that subcategory. So focusing on where most of your clients are going to fit will make it easier because we always get caught, well, what about this exception and what about that exception? Start this by the norm, start with the standard typical people, and then once you've had a few under your belt, it will make sense, and then you'll be like, oh, wait a minute, I think this one is this plus that.
That's correct.
It's like a math equation. They've got the gingival statement plus the autoimmune plus something else.
That's
so
right.
I think that just sort of stick with the normal, everyday, typical clients, and that way then you'll get more comfortable with it.
That's right. So breaking it down, so we just talked about health.
Yes.
And so you can go and define and read about what health defines as, and gingivitis. And now we're going to move over to the periodontitis category.
So that's why we wanted you guys to download the staging and grading charts, because this is really what I have in my op. This is what I encourage people to have. It's on the AAP website. You can go download it. And having this in front of you will help you understand where your client is. So we have stage 1, 2, 3, and 4. Think of the difference between stage 1 and 2. Stage 1 and 2 are very similar, and that's one of the hardest things. People are like, well, are they a stage 1? Are they a stage 2? There are differences, but stage 1 and 2 are your early to moderate perio, and there's a big division between moderate and severe perio, which would be your stage 3s and 4s. So when you first start off, try to figure out, are they at the higher end, sort of on the right side, or do they stay on the left side where they're at a lower category? That would be the best spot. Because when you're first starting, I can tell you from my experience, I thought people were stage 2, and then I went back and I'm like, oh, no, actually they were stage 1. I'm like, oh my gosh, because as I got to know it, I'm like, wait a minute, that radiographic bone loss, that's not as much as I thought it was. Or maybe I was thinking about the third molar. I'm like, wait, that pocket doesn't count. So let me go back and look at my assessment, look at my statement. So when you're looking at this chart, divide a line right down the middle. Are they early? Or are they moderate and more in the severe category? That's the easiest way to look at it.
And then you start to look for more clues
in between that.
Just further distinction.
Exactly. Because
that's really smart.
This makes sense. Like when you start getting furcations, when you start to have severe bone loss, we can all think of what those patients look like. So then you're looking in that category, where is it? The other thing is it only takes one thing in this staging for the person to move up, which is what I find when I lecture, is that people are like, but I don't want them to be a stage 3 because most of their mouth is stage 1, but this one location, this furcation, puts them into 3. But that is how it's set up, and that's why the statement would be localized. A localized stage 3, you base it on the worst spot. However, if there's a pocket on the distal where a wisdom tooth was removed, that pocket doesn't count. And so there has to be 2 adjacent teeth for it to actually count. They have to have 2 teeth side by side in order for that area to count towards the staging and grading.
And Carrie, I understand when you're in, so say you're in stage 3, you don't typically go back to being in stage 2 or stage 1. But if there was a situation where maybe emdogain was placed, so there was some bone regeneration that was successful, is that at that point that they would go to the stage maybe above?
Right.
Yes.
Okay.
Yeah. But it would have to be like successful and over time.
Yes.
Like you can't just because they had the surgery pop them into
Like the next month they're not all of a sudden.
No, they have to earn it, right?
Yes.
You know?
And that is
over
really
a period of 3 years or something.
Yeah, so
I haven't seen them define when that would happen, but I think just using your clinical judgment right away, you know what, yes, it would be there, but over time, checking with the radiographs, double check, modifying and checking your charting would put it there, but that's the only exception where people can get better.
Okay.
Other than that, people are generally hopefully staying the same with our interventions or getting worse.
So maintaining, but not necessarily without surgery going back to a better.
But we'll get into this after we break down the stages, but there also are ways to state after you've had your therapy that people are healthy. So they've actually, just like there's a category of health now, there's, periodontitis stage 2 with remission or with stability, and we'll go into that after we break down the stages. So,
somebody was asking if you could just repeat that about the teeth being side by side. And also if we could speak up a little bit louder, because I think Anne Louise is a little bit soft sometimes.
Do you want me to get it closer?
Sure, if you can.
you get it closer.
We'll edit this part out, but so if we could just be a little bit louder. Some people can hear great, but if you could just explain the teeth side by side one more time.
Go ahead, Anne Louise, you can court.
So basically, in order to make the area, you're picking the worst area, you have to have 2 adjacent teeth that are affected by periodontal disease that create the worst zone. Okay. And that's the spot that you are using to stage and grade. Okay. So if you have, so that's why if you have a wisdom tooth case and they had them out late, right?
Yes.
And then they have residual pockets on the distal of the 7s. So like everybody's thinking in their mind, just like me, of somebody that they know. Right. And this particular gentleman has 7mm pockets on the distals of his 7s, because he didn't heal up after his wisdom teeth were removed. Then because it's the 2-7 and the 3-7, that doesn't count. That takes it out of the equation. So then you have to look at other areas, but you can still talk that they have a localized area of bone loss, yes, but that's not part of a staging and grading process.
Yes.
Okay.
That's one of the exceptions that's nice to know, because that is one of the biggest objections I get is, well, what if there's this pocket from a wisdom tooth removal? How does that play? So at this point, it generally isn't part of the factor. And so they have to have 2 teeth adjoining to have it be part of the assessment. So when we're looking at the stages, for stage 1, what you're going to see is interdental cal changes of 1 to 2 millimeters, radiographic bone loss of 15%. There will be no tooth loss. This is a big thing, and I liked that this was part of a question. I'm going to admit, when I used to see people and they were missing a tooth, I'd be like, oh, yes, do you want an implant? Do you want bridges? Can we give you some ortho and we'll, align these better and fill in that space? But now my first question is, why did you lose that tooth?
Yes, yeah.
Because if they lost it from gum disease, they automatically get thrown up into stage 3 and 4.
Wow.
Okay,
And
so
that's
if you
a
have
factor.
a cracked endo tooth and you lose it, if it's doesn't count.
Okay,
Yeah.
so it's perio
It's
Only
related tooth
perio,
loss.
yeah.
Yes.
Yes.
Okay, that's a
Okay.
good
Only
distinction.
perio related, not
Right.
endo related, only perio related, which makes sense,
Yes.
right?
Right.
Because they're at a greater risk of losing more teeth at a longer period of time.
Right.
And so asking your clients now, how did you lose the tooth? When did you lose the tooth? And to be honest, some people, they just don't know.
Right.
Yeah.
But some people, they do. And so trying to extract that information, and for you looking at your clients' records, also if they're going to be losing teeth from gum disease, they automatically count towards the staging as well. So if you've got a treatment plan of taking out 5 teeth due to perio, then they would automatically fall into stage 4 because they've lost so many teeth that way.
And what is also then required is a lot of reconstruction in order to put them back into health. And that differentiates a 3 from a 4, is how much reconstruction is required in order to put them back into a full dentition. Okay. So that their function is in a norm, what would be considered a more normal function, right? Because we know if people are missing teeth that other pressures shift and shimmy, right? And then puts undue, there's no posterior support, for example, and vertical dimension gets compromised. So then we can see how, as it gets more complicated, then that's how they end up in 4.
And a very easy way, too, to figure out whether there are 1 or 2 is the horizontal versus vertical bone loss. So generally speaking, your early to moderate, those stage 1 and 2 is going to be horizontal bone. And so once you start to see vertical in your head, it's like it's tilting towards the higher end of the scale. It's starting to go basically 3 millimeters or greater radiographic bone loss, and you're going to fall into category 3 or category 4. And so, some trends to look for: is it horizontal or is it vertical? Those are distinctions between the left side and the right side. Percentage of bone loss and missing teeth are the biggest factor.
So we just want to talk about percentage bone loss. So I have this picture up here for you, so you can see quickly what the bone levels would look like on a radiograph, differentiating between 1 and 4. So what we're looking at here is the percentage of bone loss. Now you should know how to figure that out. And if you're not sure, go online and make it a project, to understand and know how percentage of bone loss needs to be able to be calculated. But we are trying to make this work within a small time frame in your chair, so that you can actually get towards doing some debridement, right? So if we look at this depiction here of radiographic bone loss, then this is a great guide to say, okay, so over here when we're looking at less than 15%, then that's going to put you in the stage 1 category. And when we're getting to the top third, then we're looking at the stage 2 and so on. We would get over to this area where you've got 50% bone loss. That's a real problem there. So then we know
we're just going to see every 9 months, right?
Yeah, exactly, right?
It'll be fine.
So we need to be able to very quickly assess from the radiograph. So that's another thing I think we need to talk about. We need to just backtrack for a second here and talk about when we're doing the periodontal evaluation, what are the components that are needed to be able to work this chart?
This is actually going to tie in about 3 questions, 2 from that we already received and a couple coming in. So yes, could we talk about the importance of, let's start here. Let's talk about the importance of having the radiographs for what we're trying to do. So
it's going to be a challenge for those independent practitioners.
That's one major question.
Yeah, for sure. And so what CDHO is aware. So you are going to have to record that you have requested radiographs from the dentist, so that can help form your decision-making tree, so that you can work down the charting. And we need to make sure that we are requesting those radiographs if you're practicing independently, and make sure that that's documented. And hopefully you do get those radiographs. And then you need to, so ideally you should have up-to-date radiographs, and the periodontal evaluation that was done today allows you then to be able to go through the classifications.
So you're using the 2 in conjunction.
That's right.
Well, more than just 2. What you see visually, your measurements, but as well the evidence you have from the radiographs.
That's right.
Because it brings up pseudopocketing, for instance.
Yes. Somebody just asked about that, the pseudopockets.
Yeah, so you have to have attachment levels, and they're and on another day we'll discuss the new version of way we can talk about mucogingival attachment levels. But for right now, you're going to use the interdental attachment levels are your guide for staging and grading, and so you have to do the math and make sure you understand where those what those numbers actually mean, right? So you have to have them, and then you'll be able to figure out what category that they're in. Okay.
And the other thing is you've got to look at, not for staging, but for the grading part, their health history. And that's where health history comes into play as well. So making sure that on a regular basis you are asking them any changes, finding out the medications they're on, what could that be related to, the dosages, that all has to be part of our record and would come into this assessment category as well.
Okay.
So it's definitely going to mean one thing if you've done your PE and you have your radiographs and you can go back, which is kind of cool right now. We're all looking back going, okay, when I started to work with you on your oral health, you would have been here, but here's where you are today.
Yes.
So that's really great. But so and that's one of the keys that you need to know of the progression of the disease, which is really about the grading, right? And so that becomes really important to have that historical look at both the periodontal evaluations and the radiographic evaluations that you have. And then as soon as you get that far, just like Carrie's saying, all of a sudden their medical history starts to take its turn as well. And so if you think you're in one section and then all of a sudden they pipe up, or you realize because they've told you I'm now taking metformin, then all of a sudden they're popped into another category, right? Because the risk is higher. So the two identified risks are smoking and diabetes. Okay. So go, Carrie.
Yeah, so those are the main things. And then like we said already, to confirm that your periodontal charting is up to date. So you've got the bleeding points, you've got the furcation, you've got the recession, you've got the mobilities, and everything is up to date. And, we should be doing them based on clients' needs, but about a year to 18 months is a good range to try to make sure that you are reevaluating this.
That's right.
And I think that that's important for perspective of it all, because it is hard to do it. The other point with radiographs is trying to make sure that when you take your radiographs that you can see bone level and that you can see through contacts and that they're readable, because I think that is part of the problem. So if you're having difficulty with x-rays, or one of your colleagues in your office is, try to reach out, give them some pointers, because then you can really have accurate information so you can really help your clients. I think that's a big factor for sure, is radiographs and the quality of radiographs.
Right.
Yeah.
And then we're going to talk about the distribution of the staging and grading. Is it a generalized or is it localized?
Yes.
And is it molar incisor? Okay. So, and for all of you who are going, what is molar incisor? It is the old version of juvenile periodontitis, just given a new name, as it would actually look on radiographs as molar and incisor pattern.
Yeah.
So if you're wondering if they're the same thing, because you've been around a while, just maybe 1 or 2 days, yes, you're quite right. It is a new name for juvenile periodontitis.
Yeah, I was going to ask that.
Yeah.
For a friend, I was going to. Thank you for clarifying that.
No problem. No problem. Perfect.
So we have stage 1 and 2. The big difference between stage 1 and stage 2 is the pocket depth. So stage 1 will be 4 millimeters and stage 2 is 5 millimeters.
Sorry, say that one more time.
So for stage 1, the pocket depths will be up to 4 millimeters. And stage 2 is up to 5 millimeters.
Okay.
Yeah. And so that is outlined in the charts here on the bottom, and again, mostly horizontal. Once we pass that division, this is where we get a bit more exciting, where we start adding in a lot more factors, such as furcations, angular bone loss, and teeth that are missing from periodontal disease. So if they're missing up to 4 teeth, only 4, they will fall into stage 3. Okay. If they've lost 5, or they have treatment plan to lose up to 5, then they fall into 4.
So even treatment plans. So it's not necessarily that they're gone yet, but they are treatment planned to be extracted.
Right. Yeah.
That puts them in that category as well. Okay.
Yeah.
Yeah, that is one of those little great questions about where are they, because truly that's where they're going to end up.
That's right. And it's gonna and you would know that because it's gonna require a lot of rehabilitation to get them back. Right. So that would be a more complex case.
Okay.
And then you're definitely seeing susceptibility to the remaining teeth.
Yes.
Right? Okay. So that's part of staging.
Yes.
Okay.
Yeah.
And so the next part, and again, look at these charts, because in this, there are all the details all laid out, and this is a really great factor. So what I tell my team when I've worked with them, I'm like, start one spot and just take your finger and work your way across. You're just looking for one category, and that's where you're going to end up. So it's a work in progress, and that's why you can kind of laterally move right across till you find that one spot that matches what you're doing.
Yes. So I did send this out through an email if you're on RDHU's website. So if you go to rdhu.ca, it will be in the follow-up email as well. But everyone received this yesterday and as well as last week. So this is what you can laminate, print and laminate.
Yes.
Just a couple of questions. Without previous radiographs on a new client, is it acceptable to postpone grading if there's no medical indicators?
No, you'd still want to grade them. Yeah. You just wouldn't have that as a category. So when we go to grading, if you've got the table, flip it over to have the grading stage. If you don't have past history, that category just doesn't count towards choosing your grade for that patient at that time. And so that's where it wouldn't count, but you would still know currently what their percentage of bone loss is. You would know currently as well. This is where you bring in modifying factors such as smoking and diabetes. And so I think the easy way to think of grading is every patient starts in the middle. They start in category B. Right. And they either get upgraded to first class in category A, which means they're doing really well, and they're kind of upgraded to category A, or they're downgraded to category C. So think of everybody as a B, and then find a reason why they'd go right or left.
Very good.
Yes. So then if you didn't have enough radiographic evidence to put them up to A, they'd stay, because it could be the same, and we had comment come through about people who just flat out refuse radiographs.
Yes. Well, then you're making that classification decision based on what you have.
Yes.
On the data, the clinical data that you have gathered today. Right.
And somebody else is saying that their office only takes bite wings.
Yep.
And it's my understanding that in order to do this assessment, we need PAs of all the teeth.
I think vertical bite wings is
bite wings
for sure.
Yeah. And even panorexes, things like that. You can look at the history of the panorex, and this comes down to conversations with other people in your office, speaking to the dentist, speaking to other professionals, and explaining the reasons why you'd like to have additional radiographs. Right. And so even trying to figure out a way to modify your initial new patient's exams or updating records, but looking at panorexes, and you do just need something, and bite wings is a good way to start. And kind of going back to verticals are probably great once you're definitely into stage 3s and 4s, or making sure on those horizontals you can see the bone level.
That's right. Exactly, Carrie. I think that when you're looking at the progression of disease, you need to look at the age of your client.
Yes.
Okay?
Yes.
So like my mom, who's like 86, has very little bone loss. So she would definitely earn to be in an A category. Okay. So you can look, if the age of your client is more than the level of bone loss, then you are going to be looking at B or A. If the level of bone loss is greater, the amount of bone loss, the percentage of bone loss is greater than their age, they're going to be in C.
Okay.
Does that make sense?
That's an easier way to look at this, because I went into hygiene because I love math. I totally do. And now most people panic when you look here and it says percentage of bone loss over age. I'm like, good news is I have a cell phone and I've got a computer that can do my math, okay? Because that is not my strong point. I'll stick to what I'm good at. Yeah. That's not one thing. Right. And I think how you just described it as figure out their age, because right away what do I think of? People, and I had this gentleman that came in, he was 30 and he was losing 3 teeth from perio. Okay. And it's like, he was off the Richter scale as far as infection, but that is a good example where age does not equal bone level, and that's an extreme case for his lifetime. Right. We really have to stay on top of him. We've got to get the right instruments in there. We've got to make sure we see him regularly. Everything else.
Yeah.
Okay. So someone like your client, who might have the same level of bone loss as someone who is, say, 65, he is now in a higher risk category based on the equation.
Yes.
Right?
Yes. Exactly.
So
and it's the whole thing about grading is about the progression of disease. So for some people, if we can stabilize them, like when they're 30 and they had a dramatic amount of bone loss, they're waiting for their friends to grow older and lose more bone, right? While they stay stable. right? That's their goal,
okay.
right?
Keep them stable. Yeah.
Then as they get older and they've been stable, they could actually move down a grade. Okay.
Yes.
Once they exceed, like their age exceeds their percentage of bone loss.
And so the staging, generally, you don't want that to change. Like, there's the odd exception where they get better.
Right.
But
Or
for the
they
most
have
part,
surgery.
they get,
Or
so they have surgery to get better with the stage.
Yeah.
But with grading, it can change. And this is where your statement might change 3 months, in a 3-month appointment, because maybe they started smoking. And so they got upgraded to category A, but now they're smokers, so they would be downgraded to category B because they're smoking. And you've got to look at the frequency of their smoking. And the other factor you've got to bring in is diabetes. So if they have diabetes, they automatically will be in B if they're stable.
Okay.
If their diabetes is unstable, they get downgraded to C.
Yes.
So there's a lot of
Yeah, there is a lot of factors.
Yeah.
And the great part about the way that this is laid out is it's perfectly suited for chairside discussion, right? And you can say, here's where you are, right?
Yes.
You know? So, and therefore, this is like serious, and here's the treatment plan then, therefore. You need to be coming in and I need to be doing my job and you doing your job in order that we can get this under control.
Well, the dental hygiene diagnosis is based on all of our observations of everything. And so our observation would be, now I'm observing that you're in stage 2, grade B, and this is where we're doing, because this is going to lead to a treatment plan. That's what this dental hygiene diagnosis is to do, is to lead us to a treatment plan. And, we have to figure out where and what that's going to look like based on our client's needs.
Carrie, that leads me to one of the questions that I'm getting a lot is as far as the dental hygiene diagnosis statement goes, so there's instructors out there saying that dental hygienists can't diagnose periodontal disease.
Right.
And we'll just bring it down to Ontario for the sake of this question, but in Ontario, what can we do as hygienists as far as a diagnosis goes?
So we were talking with CDHO on Friday, and they said in our dental hygiene diagnosis, we can state that they're stage 2, grade B, based on what we find. Because that dental hygiene diagnosis is what we're doing. We're not diagnosing periodontal disease. We're making a dental hygiene diagnosis, and we're able to do that on the observational data we've collected. And so we're just going to use different words now and ways of explaining stage 1, 2, 3, 4, grade A, B, C. And then you would write things like due to diabetes, due to smoking, due to lupus, due to whatever it is that's related to that patient in your statement.
That's right. So we're looking at, it's an interpretation of your assessment. You've gathered clinical data, and now you're able to classify this client. Okay. Just like if you're getting bent around it, just think about that you've been classifying for patients for however long you've been practicing, right? This is just another classifying thing. And we are using it to classify. So the client falls under this classification.
Okay. Right. And the classification leads to the treatment plan. And that's really, this is a guide to move us through to what does this client need based on their classification. And you've used many words, and we've had many discussions on this over the last few months. And think of this, some people get their head wrapped around it. It's almost like an indice. Where do they fit into the indice? When you're doing your indices, this number means this. This is almost like an indice.
Yeah.
And I think that was a really great way to wrap your head around it, and for people to kind of relax.
Yes.
And I think it's going to make the public be more acceptive of the treatment planning, because it's just like when you hear, I hate to say it, but you hear you have stage 2 cancer or stage, you know what I mean? People are kind of used to that. So when we start talking staging in perio, it's pretty serious, right? So I'm stage 4 perio. That's not good.
And it's language they're used to hearing when it comes to stages.
Well, when you're into cancer, you want to hear the word remission. And the good news is now, just like we have health, we have ways of using statements. So you've gone through therapy, and now you can use words like remission and stability to state the patient is stage 2, grade B, in remission due to.
Yeah.
Right.
And so you can actually state that they're healthy after.
Mm-hmm.
And that's their patient goal. My goal is I want to get this patient into remission. And that brings in, again, trying to understand the difference between how do you choose stability and how do you choose remission. Start by just using the word remission, and then you'll figure out the little differences. Because again, there's a few little nuances of understanding when to use stability and when to use remission or control.
Yes,
Exactly.
there's lots of definitions in this particular document as well, and Carrie and I talk about them all, and we just want you to start to get familiar, because it's by the end of the year you'll be much better than you are today, you know, and understanding when someone is stable or unstable. So we can just even think that the person who's coming in every 9 months, because that's what they think they should be doing, is probably unstable, right? So
and they might be, and if they should be coming in every 3 months, and that might lead to a higher grade. Right. Because they're not accepting care. So where if they came in every 3 months, but because they're a 9 month and they're on medication and they've got a dry mouth and all those things, they might fall up into a higher grade.
Right.
That's and one of the things that they talk about in this is you have to use your clinical expertise to guide you.
Yes.
So if you think that they are, so the decision you may amend but in another few months because your client is not responding to treatment, or they have, you know, broken their arm, or they're having trouble using something. So we have it's multifactorial, and our opinion of their clinical level the interpretation does fall into the category. It talks about that. Is the client providing themselves in an environment where they can change things? Are you the person that should be providing the care? Is it the right time, the right place? All of those things, right? So that all comes into factors.
With us coming down to time, I want to make sure we've got time to talk about implants, because there's a few specific things about implants, but I'll let you take over for implants for sure. How's that?
And I'll just ask you the question that came in about implants.
Sounds good.
Make sure we address it.
Exactly.
Do we have to do this for each implant, and how would you document it?
Exactly. Thank you so much for asking that. Great question. You do have to come up with a classification for each implant.
Yes.
Sorry. So now I'm going to cough.
Drink your water.
So basically, thank you. I'll try not to choke too. Okay, so basically there are 4 categories in the implant section. One is of implant health. So that's when the tissue is pale, pink, coloring well, not bleeding on probing, all those good things, no separation. Then we have implant mucositis. So then you're going to have inflammation, and you will get bleeding on probing, and you can get some separation or not. Okay, but you're definitely seeing inflammation, and then you get implant mucositis, which is going to be radiographically. You're going to have all those things, including separation and a radiographic evidence of bone that's being lost. So if your client has 1 implant, then you only have to make 1 classification statement. So you're going to make a statement regarding their teeth, and then you're going to make a statement regarding their implant. If they have more than 1 implant, then you have to do an evaluation for each implant. Yes. Okay. So if you, for example, somebody has, I'll think of one of my clients that she wears, she has a full upper denture on locators, and those implants are doing well. One of them has inflammation, okay, but the rest are healthy. So I can put the tooth numbers that they represent and say in implants, health has been classified for implant number blah, blah, blah. Okay. On implant number 46 is implant, she has implantitis on that particular implant because she has lost bone.
So you have to, they can have the same statement, but you'd have to specify which individual implants go to that statement.
That's correct.
And then carry on to the next one.
That's
right.
And
if they have a mouth just of implants, you would just make implant statements.
Okay.
So if it's just implants that are remaining, it's just implant statements.
Right. And I understand that for some, you're going to have a screwed in superstructure.
Yes.
And you can only deal with what you can see. So if today's not the day that the superstructure is coming off, then you may have to say that you're going to put the parameters. Things look, they fall into the category of health because you've done your 5-step evaluation of it, but you weren't able to probe it today because the superstructure was still on it.
Right.
Okay. So then, so when you have the superstructure off, that's the time where you have to get, the radiographs together again with the charting in order to move forward and make a complete statement.
Yes.
Okay.
Perfect. So that answers the question about the implant, and then as well the documentation for the implants.
Yes.
One of the other questions I want to make sure we get to was just about documentation in general. So the question was, I wondered what we need to include in our documentation for an initial perio assessment regarding staging and grading. So that kind of encompasses everything you've talked about, but bringing it back to, or bringing it down to a very, very practical, what's going in the chart. Is it possible to address that?
So I would say that if you're doing your periodontal evaluation today, your full periodontal evaluation on your client, then you are going to figure out whether they're in health, gingivitis, or they have some bone loss that puts them into the periodontitis classification. And then once you determine which one of those 3 areas that they are belonging in for their teeth, then you proceed to, in health, there's a definition. In gingivitis, there's going to be incipient, localized, or generalized. And in periodontitis, you're going to go through the staging and grading. So then those words will then become part of your diagnostic statement for that day, because it's meant to engage and then to create a treatment plan and then work on that treatment plan.
So that kind of answers the final question we have, which is when this is all taking place.
Right.
Is it at the new client or patient exam, or is it for every existing?
There's questions about that too. They're asking, how often does this mean I have to do this every 3 months? But that's not the case. No.
It's when you're doing your complete exam, and that's when we spoke with CDHO. They said when you do your complete exam, that's when you would come up with this new diagnosis.
And then how often?
And so based on clients' needs, it could be 6 months, it could be a year and a half. You look at that client and you determine the frequency of that.
Right.
And so
could
that's
be
what
a year.
It could be a year, it could be 18 months, it could be, 6 months.
Client specific.
It
But
is,
not
definitely.
you're not going to do a full mouth pair assessment every 3 months. They're asking.
And that's not what's expected.
No, and also there's still some questions about, can we do this, or is it the dentist? But yes, that's what we're saying, that it is
well within our scope, because it's a classification. The classification actually, even for the dentist, leads to the diagnosis. They have to classify first, and they all talk about that when I've been listening to their lectures, that they have to accumulate all the information in staging and grading and using these classifications in order then to create their own diagnosis. And that's exactly what we are creating, is our own dental hygiene diagnosis with that.
Yes, and we can use words like periodontitis and gingivitis. Those are words that we're able to use.
But not periodontal disease.
What we're saying is that there's inflammation and there's evidence of inflammation, and so we're able to say that.
Okay.
Yeah.
Now this is like a huge topic, and today was really meant to be, if this is the RDH view, we have discussions, we share what we can, but there's so much to it. So we wanted to kind of just demystify as much as we can, and then from here we'll send you extra resources, and then you can look into taking other courses and until you feel more comfortable in this. But we're not going to get all the answers in a 1-hour talk show.
I think the best thing for the people to take away is look at on Monday morning when you get back to work, unless you're working tomorrow, choose one person a day and just do it. Do it before lunch, so then you get a little bit of a break. Do it at the end of the day. Stick with the normal people, because if you don't start soon, you're never going to start, and it won't become a habit, and you won't get comfortable. Reach out to the courses, do some more courses, because it's a language. You're going to start to layer it. If some of you've listened to us and you're like, okay, that might make sense from just hearing it 2 and 3 times. So
exactly.
Anna Louise and I both have courses coming up in the near future. We give them at RDHU, so please check out RDHU if you're looking for additional resources. If you'd like Anna Louise or I to come out to your associations, come across
or even
to the provinces,
in offices. We organize in-office courses too, where you might have, like tomorrow Carrie's going somewhere where there's, you know, all the dental hygienists from all their practices. So we do in-office courses as well. So just feel free to reach out to us, and we can put something together for you. There's a whole lot of questions, but I think we answered all the ones that were screened, and I think we've answered pretty much all of them. We are going to put this together again and put it on the RDHU portal. Yeah. So we will insert the pictures that Anna Louise has, and we'll add all the extra resources so that you can watch this again for future viewing. Yeah. And I think that's
the DHQ.
Dental Hygiene Quarterly, yes, thank you.
Another one. Yeah, there is, I did a very short initial assessment and discussion on what all the different parts are. It might be a nice additional online course that you can do and download, and you know, there will be additional stuff coming forward, but it's another great
and
resources.
More coming this year.
Yes, I will be doing another one. So you know, look forward to that on additional layers and additional ways of learning. And the more that you listen to this, the more it will start to make sense.
Yeah,
exactly.
And thanks so much, Carrie and Anna Louise. You both just have so much knowledge with something that is causing some anxiety for all of us. Yes. So we really appreciate having you as colleagues, as friends.
Okay, Anna Louise and I have had many hours of anxiety. We just, you know, we have
pushed through.
We've pushed through. We have come out on the other side, and so will you. Don't worry.
Yeah, exactly. Yeah, we wish you all the best, and we want you to know that we're with you here, because we get that it's not easy, but you need to chunk it out. Okay, it's not going to it's not going anywhere. So it's going to grow. So
it might change. Like what we're talking about now, you might find that there is an update, and so the foundations, the framework, these tables aren't going to change, and so just start there. Start that aspect.
Exactly. Yeah.
So make sure, just to say, make sure that you opt into RDH. I think most of you are already in our membership, but if you aren't, that's how we're going to send you out the quiz as well and the extra resources. So if you're not receiving our On Track Tuesday emails or just emails in general, then just go to rdhu.ca. There is a web form, you opt in, and then you'll get all that information. We'll have a link to the quiz, you'll have a certificate, and any extra resources. We'll have the pictures. They really want to see your pictures, if that's okay with you, Anna Louise. Yeah. So thank you so much for joining us. That was a lot of fun.
Yeah, it was.
And we'll see you next time.
Sure.
Thanks. Take
care.
Bye.